You can sit down. Yeah, okay. So, good morning, everybody. And you know that mitral stenosis is a very commonly kept long case. In most of the examinations, in practical examination, it is always there. And we all know that mitral stenosis, especially in Asian countries and developing countries, more common cause is the rheumatic fever. And it's almost more common in females, almost 8:1. And in young females, childbearing age. So many of them will be, become symptomatic during their pregnancy. And that's how, pregnancy with mitral stenosis is one of the most commonly kept cases for you. And also it is commonly asked question in theory as well. So it's very important that you should know as postgraduates more about pregnancy with mitral stenosis. So along with me, Dr.Mariam from Jubilee Mission Medical College is there, and also 2 students from Jubilee Medical College. So first, I would like them to introduce themselves before we go ahead with the case.
Hello, my name is Selvin Thomas, third year postgraduate resident from Jubilee Mission Medical College.
My name is Nino Rosefall, third year postgraduate from Jubilee Mission Medical College.
Okay, you can.
Good morning. My patient is 23-year-old female. She's a BA graduate and housewife. She's hailing from Thrissur. She's a preemie. She has presented at 38 weeks of gestational age for safe confinement of pregnancy. The informant is the patient. Presenting complaints: generalized fatigability for 2 months, breathlessness on exertion for 1 month, corresponding to 34 weeks of gestational age, and she is admitted for safe confinement. History of present illness: she has come here with breathlessness, which was gradual in onset, progressive in nature. This breathlessness initially was on climbing stairs, and it progressed to walking short distance from room to kitchen or bathroom. Aggravated on exertion, like sweeping the floor and washing clothes. It was relieved by rest. No history of breathlessness on lying down. No history of paroxysms of breathlessness at night. No history of cough, blood in sputum, syncope, chest pain. No history of decreased urine output or abdominal pain or leg pain or weakness in face or limbs. No history of fever. No history of awareness of her own heart sounds. No history of difficulty in swallowing or change in voice. No history of recurrent respiratory tract infections or bluish discoloration of skin and mucous membrane on squatting. Obstetric history: first trimester. The pregnancy was confirmed by UPT after 45 days of amenorrhea. It was confirmed by ultrasound. She was a booked case and fully immunized. No history of hospital admission for nausea, vomiting. No history of heartburn. Folic acid tablets were taken. No history of any other drug intake. No history of infections. No history of exposure to radiation. Second trimester, quickening was felt at 20 weeks of gestational age. Iron tablets were taken. TT prophylaxis was taken, 2 doses. No history of nausea and vomiting. Anomaly scan was done, which was found to be normal. No history of headache or blurring of vision or leg swelling or bleeding PV. Third trimester, she continues to feel fetal movements. Growth scan done, which was normal. Leg swelling present since 1 month. Dependent edema, more in feet and increases as day progressed. And it was not associated with puffiness of face. No history of headache or blurring of vision or bleeding PV. Patient complains of breathing difficulty since 1 month, which was aggravated on exertion and relieved by rest. Past history: she gives history of fever associated with sore throat and joint pain at the age of 10 years. She was on injection penicillin every 21 days till the age of 20 years. Not on medication since 21 years of age. Not a known case of diabetes, hypertension, tuberculosis, bronchial asthma, epilepsy, or no history of TIA. Menstrual history: she attained menarche at 12 years of age, regular cycles. Marital history: married for 2 years, spontaneous conception. Previous surgeries or anesthesia exposure: nil significant. Personal history: mixed diet, bowel and bladder habits normal, sleep and appetite normal. Family history: no similar complaints in the siblings in the family. Her parents are alive and no significant comorbidities in them. Drug history, no drug allergies, history of penicillin injection till 20 years of age, iron and folic acid tablets were taken. On admission, cardiology consultation was sought and she was told to have a diseased valvular heart, for which she was started on tab metoprolol 25 mg OD. General examination. After obtaining consent, patient examined in well-lit, silent room. She is conscious, oriented, cooperative, lying down comfortably. She was moderately built and nourished. Pallor present, conjunctiva was pale. Bilateral pitting pedal edema extending to ankle. No icterus in sclera, mucous membrane and skin. No clubbing. No cyanosis in extremities, tip of nose, tongue, mucous membrane. No lymphadenopathy. No features suggestive of infective endocarditis. Peripheral veins were visible for cannulation. Skin, hair, and nails appears to be normal. Spine, alignment is normal. Spinous process palpable. Interspinous space was normal. All movements of spine normal. Height is 160 centimeter. Weight is 70 kg. BMI is 26.4 kg. Pre-pregnant body weight is 57 kg. Vitals, pulse rate is 72 beats per minute, rhythm regular, decreased volume, condition of vessel wall normal, no pulse deficit, all peripheral pulses felt. BP recorded in right arm sitting position, 120/70 millimeters of mercury. Her standing BP is 110/65 millimeters of mercury. Saturation is 100% in room air. Temperature normal. Respiratory rate 14 per minute. JVP elevated more than 2 centimeter above manubrium sternum with patient propped up to 45 degrees. Hepatojugular reflex could not be elicited. METS is more 4. NYHA 3. Airway, nasal patency normal, mouth opening adequate, upper lip bite test normal, thyromental distance more than 6.5, neck movements normal, Malampatti 2, dentition normal, no dental caries, loose tooth or dentures. Systemic examination, cardiovascular system, inspection, neck normal, trachea midline, chest wall, bilateral symmetrical, no deformity, no precordial bulge or scars or sinuses, no visible or dilated veins, apical pulse not visualized. Palpation, inspection findings were confirmed. Apical pulse localized to fifth intercostal space 1 centimeter medial to mid-clavicular line. Tapping in nature. Parasternal heave on left sternal border. Palpated close to and parallel to left sternal border using ulnar border of the hand. No diastolic thrill in the mitral area. Percussion not done. Auscultation. Mitral area, fifth intercostal space. Loud S1 is heard. S2 present. Rough rumbling mid-diastolic murmur heard in mitral area, grade 2 to 3, with an opening snap and ending with a pre-systolic accentuation, heard better with bell of stethoscope, with patient in left lateral position at end of expiration. Pulmonary area, loud P2. All other areas, S1, S2 heard, no other murmurs, no added sounds. Obstetric examination, inspection, abdomen longitudinally distended, umbilicus midline, linea nigra and stria gravidarum present, no visible pulsation, no scars or sinuses, fetal movements visible during examination, palpation, fundal height 38 corresponds to 36 weeks of gestation, fundal grip firm, round, non-ballotable mass felt corresponding to breech, lateral grip flat, slightly curved linear mass felt on the left side spine, first pelvic grip hard globular ballotable mass, probably head. Respiratory system, normal vesicular breath sounds, no added sounds. CNS, no focal neurological deficits. Diagnosis, 23-year-old primey with 38 weeks of life intrauterine gestation with mitral valvular disease, probably mitral stenosis, probably due to rheumatic heart disease, with features of pulmonary hypertension, not in failure, in sinus rhythm, not in labor. She is admitted for safe confinement.
Okay, thank you, Ninu. You have, please sit down. You have taken a very elaborative history and also examination is also very well done. So, one of the questions commonly we can ask you here is, because patient was almost asymptomatic before, she became pregnant. And during pregnancy also, she was almost asymptomatic. And now, in the third trimester, she has become symptomatic. Now, what may be the reason why she has become symptomatic now?
During pregnancy, there are many physiological changes that happen in every system. In cardiovascular system, the cardiac output increases by 50%, heart rate increases by 15%, and stroke volume increases by 30%. Also, there is increase in blood volume by 50%. So, as the blood volume increases, the preload increases, left atrial pressure rises, and there is back pressure leading to pulmonary congestion, which can result in dyspnea, progressive dyspnea after 30 weeks of gestation.
Is it only because the blood volume is increased she will become symptomatic, or is it the heart rate? Now you said that in pregnancy, as the pregnancy advances, the heart rate also keep increasing, almost 15 to 20% increase in the heart rate occurs. Is it heart rate is also very important in producing these patients to become symptomatic?
Yes.
Why increase in heart rate in MS patients can produce to make them symptomatic? Okay, you can answer.
Because as the heart here, there is a fixed low output cardiac state, so the heart require enough time for relaxation and depend upon the last ejection systolic kick for the cardiac output. If the patient is having increased heart rate, so there won't be enough time for the joint diastole or the relaxation phase. So the cardiac output may decrease further, which may be worsening to these patients.
Yeah, because most important thing here is there is an obstruction for the flow of blood from the left atrium to the left ventricle. So the time constant for filling of the left ventricle is prolonged. So once the time constant for filling of the left ventricle is prolonged, and left ventricle gets filled in only during diastole. So if heart rate increases, the diastolic period also decreases. So that is the reason, left atrial pressure. Everything is because of the left atrial pressure increase, the back pressure effects. Okay, another thing you said that she became symptomatic, and usually you assess the symptoms, especially the breathlessness, based on NYHA classification. You said that she is in now class 3 NYHA. So even majority of the pregnant women also will have some amount of breathlessness. There is restriction of the physical activity. So how do you differentiate whether patient has got cardiac disease and having breathlessness, especially the pregnant women, and normal pregnancy also will have breathlessness?
Her dyspnea gradually progressed from NYHA 2 to NYHA 3. Also, she gives history in cardiac patient. There may be history of orthopnea and paroxysmal nocturnal dyspnea also. She gives history of a childhood fever and joint pain, and she was on injection penicillin for the past 20 years. So, which may point my...
No, usually you should always think majority of the women without cardiac disease, when they become pregnant, gradually the breathlessness will be there, but usually it will be NYHA class 1 to class 2. It will not be class 3 or class 4. So in these, when you suspect that they may have cardiac disease is when they have more severe breathlessness, especially the class 3 or even class 4. It will never be present in normal pregnancy. That's how it's very important. Next, another question for you is, why do you want to quantify this breathlessness? What is the importance of this?
We want to quantify the breathlessness because we can quantify it according to NYHA classification, or also using Royson's criteria. According to this criteria, we can assess the severity of the breathlessness these patients are having.
Why should you know whether breathlessness is severe or less severe? What is the importance for you as an anesthesiologist?
Because it will give us the outcome, the intraoperative. And
does it change your method of management? Because one thing you should always realize, whatever the things you are taking history, and the history what you take is not for actually diagnosis like any medicine PG will be doing. Here you are doing a pre-anesthetic evaluation. You are trying to evaluate the patient finally to know what all the investigations you would like to do, what the preparation you have to do, and what is the method of managing these anesthetic management of these patients. So definitely the severity of the breathlessness will give you an indication of the severity of the disease. So if the severity of the disease is more, does it change your method of managing this patient anesthetic management?
Yes.
So how does it change? For example, let us say that this patient is class 4 breathlessness and she is being posted for an emergency section. Does it change your method of managing?
Normally, if a mild to moderate case, I would go ahead with the graded epidural or combined spinal
Exactly,
epidural. But
exactly.
if this patient is having severe MS and posted for emergency section, I would go ahead with general anesthesia.
Yeah, that is how, your total, even regional anesthesia also. Otherwise, you would have given a spinal anesthesia and then you would have managed. But here, can you give a spinal anesthesia and can manage?
No.
So, sudden decrease of systemic vascular resistance, they will not be able to tolerate. So, that's how, everything is important. So, one more thing, you said that no history of angina. So, in a young lady, do you expect her to have angina or chest pain? Or if she gives you history of chest pain, what may be the reason here in an MS patient?
In an MS patient, the chest pain it may be due to the LV is hypoplastic, but the RV is hypertrophic. So there is increased demand. And also, as the LV is hypoplastic, there is decreased left ventricular end diastolic volume, and hence cardiac output is also decreased. So there is supply-demand mismatch. So the angina may be because of, chest pain may be because of that. And decreased coronary perfusion.
It's because the right ventricular hypertrophy, right ventricular oxygen demand is increased. Supply, you see, the right ventricle is always supplied both during systole and diastole. But here, because the right ventricular pressures have increased, so the supply may be only during diastole, again for the right ventricle. And the demand is increased because it is hypertrophied, and also the afterload is increased because the pulmonary vascular resistance has increased. So if they develop angina, it may be due to the right ventricular hypertrophy rather than the left ventricular hypertrophy. Okay, now this patient is on metoprolol. It's only after the patient was admitted to the hospital, they've been started with metoprolol. Why metoprolol for a MS patient?
Because we want to control the rate for this patient. We have to maintain the heart rate around 60 to 80 in this patient. Because by controlling the heart rate, we can give enough time for the heart to pump the blood. Because here there is a fixed low cardiac output state. So increasing the heart rate will cause a abruption, or the mechanism is
already we have discussed, isn't it?
Yeah.
So you cannot have a short diastolic period in these patients. So that is why majority of these patients will be on beta blockers, because most of the time in pregnancy we will avoid beta blockers because it can produce IUGR, isn't it? Intrauterine growth retardation. So why metoprolol? Can I give propranolol in this patient? That's also a beta blocker, though it is a non-selective beta blocker.
It is not suggested because it can lead to IUGR and...
No, propranolol, non-selective, has got both beta 1 and beta 2 antagonistic properties. What happens if beta 2 is also antagonized? What happens to the uterus? Uterus
relaxes.
Relaxes or contracts?
Contracts.
You give tocolytic agents, means beta 2 agonist you will be giving, isn't it, to relax the uterus. But if you give a non-selective beta blocker, there is a probability of uterus contracting which we should avoid till the mother goes goes into the labor. So suppose, what is the most common dysrhythmia they are prone for?
Most common, they are prone for atrial fibrillation.
Okay. So why atrial fibrillation, most common dysrhythmia?
Because here the mitral area is lower, so there will be increased pressure in the atrium, left atrium. So initially the pressure, this pressure causes dilatation of the left atrium. So there will be, this will make them prone for developing atrial fibrillation because of the electrical vectors are mismatched in the left atrium, causing
mainly the left atrium is dilated and volume overload is there, pressure overload, both volume and pressure overload. Because of this hypertrophy of the ventricle plus dilatation of the atrium. So because of this dilatation and hypertrophy of the atrium, it is more prone for supraventricular dysrhythmias, and most common is atrial fibrillation. So why should you know that she is prone for atrial fibrillation? Or for example, many of these patients may present to you already having an atrial fibrillation. So any particular extra medication the patient can be on?
If the patient is having atrial fibrillation, she might be on anticoagulants also. In pregnancy, we have to be bothered about anticoagulants because less than 12 weeks of pregnancy, warfarin, usually the patients may be on vitamin K antagonists like warfarin. The pregnant patients should, if 5 to 10 mg per kg, warfarin is okay, but more than that, warfarin is not indicated in the first trimester.
No.
Because
If the mother is on warfarin less than 5 milligrams, what has been found is it may not produce so much of increased incidence of teratogenicity. Like warfarin embryopathy is very common if it is more than, if the mother is taking more than 5 milligrams. So you may have to change over
to a low molecular weight heparin in the 12 weeks, till 12 weeks. Then 12 to 36 weeks, the mother has to be put on warfarin. Then after 36 weeks, we have to again start on low molecular weight heparin.
Now, why do you want to change over again after 36 weeks from warfarin?
Warfarin has a prolonged half-life.
What is the half-life?
4 to 50 hours.
36 to 48 hours. Acetram? Because these are the oral anticoagulants many of these patients will be on. And usually you avoid direct acting oral anticoagulants like rivaroxaban and dabigatran. So majority of the times they'll be on these oral anticoagulants like warfarin, vitamin K antagonists. So usually it is a shorter half-life when compared to warfarin. It's about 24 hours. So that also you should always know when to stop, how long you have to stop these drugs. No, but why should you stop? Okay, one is longer half-life. So what happens if you continue? So why should you, because of its longer half-life, you have to stop warfarin before or after she attains 36 weeks?
We have to, if the patient is on warfarin after 36 weeks, if the patient suddenly presents in labor, we cannot give any regional anesthesia, and during the labor, the fetus is prone for intracranial hemorrhages during the when the baby passes through the birth canal.
No. Not only that, after 36 hours, you will have to reverse it. Reversing is a real problem. Suddenly, when compared to other surgeries and when they go for emergency section, hardly you will have time to even reverse. So that is one of the problems. So that's why you switch over to parenteral anticoagulants, and especially low molecular weight heparin, isn't it? Or initially you can go for low molecular weight heparin. After that, what you will do? For example, now the patient has been planned for induction of labor now. Will you change it from low molecular weight heparin to
unfractionated heparin?
Yeah.
Then we have to stop unfractionated heparin 6 hours prior to induction.
So why again change over from low molecular weight heparin to unfractionated heparin?
Low molecular weight heparin if it is a prophylactic dose, it has to be stopped 12 hours prior to the surgery, and if it is a therapeutic dose, 24 hours prior to the surgery. Whereas unfractionated heparin, it has a shorter half-life, so it can be stopped 6 hours prior to the surgery.
So you may have to go for IV infusion of unfractionated heparin and stop 6 hours before, and afterwards you can start after 4 hours after the procedure is over. That is how that helps. So it's very important to know about whether the patient is on anticoagulant therapy or not. So you have a lot of things you have to think about, how to manage if the patient is on oral anticoagulants. Okay, now coming to a lot of questions can be asked in the history itself, but we do not have much time. So for your examination, again, the loud S1 you said. So what is the importance of knowing whether the loud S1 is there or not?
The loud S1 is because the valve is thickened, but the valve is also pliable. It is inversely proportional to the severity of the MS. The valve is closed. The sound is because of the closure of the mitral valve against high pressure gradient. The LA pressure increases and the gradient also increases. The valve valve is kept open because of the high gradient.
Suppose the patient had loud S1. After some time, now the loudness is gone. There is no, it has become very soft. So why should you know about this? Any particular procedure if the patient requires?
It may indicate the severity has increased. We can suggest the patient for...
So when the loudness goes off? What
when
condition
it
of
is
the,
associated with mitral regurgitation also,
one is mitral
then
regurgitation.
calcification of the mitral valve.
Yes, calcification. So if the valve is calcified or if there is a MR is there, mitral regurgitation, can we go for percutaneous balloon valvuloplasty for
No.
these patients?
We have to
Now
go
we'll have
for
to go for only
replacement.
that is another thing which you as an anesthesiologist, you should always check for it. Okay, many of these patients as an anesthesiologist, so you may require to anesthetize them for when they are posted for labor analgesia, because regular vaginal delivery is more often is indicated unless the cesarean section is only for obstetric indications, or if the patient is in failure, or if the patient has got severe mitral stenosis, or if the patient has got pulmonary hypertension, then only cesarean section. Or if the patient, as you said, that patient will be on anticoagulants, oral anticoagulants, and goes for labor before 36 weeks, again you require to go for section. So that is one, for section you may have to anesthetize them. For labor analgesia, again you are required. And many of these patients, pregnancy may be contraindicated. Suppose if they have a prosthetic valve, mechanical prosthetic valve, then they may come for MTP. Then again you are required. Or they may be posted for non-obstetric surgeries during the pregnancy, like maybe cholecystectomy or appendicectomy, then also you are required. So multiple, or even for procedures like balloon mitral valvuloplasty or even valve replacement or valve repair, anesthesia is required. So let us say that we will discuss two conditions. One is she is posted for an elective labor, now she is being induced, or elective section. So what are the investigations you would like to do in this patient?
I would go ahead with routine blood investigations, including hemoglobin. The HB is checked because the patient can have physiological anemia or nutritional anemia. Then total count, because it can point towards any infection. Then blood group and cross matching should be done. Then renal function test and liver function test, because the patient can have features of failure and the RFT may be raised, and because of congestive hepatomegaly, the enzymes may be elevated. Then coagulation profile has to be done if the patient is on anticoagulation. Then electrolytes, because the patient can be on digoxin, so the potassium has to be checked.
When the patient can be on digoxin?
If the patient has had history of AF, or if the patient is on failure.
Yeah, many times for AF and failure, the patient may be on digoxin. So you said electrolytes for digoxin. Why? Which electrolyte for digoxin?
Potassium, hypokalemia.
Hypokalemia can increase the toxicity of digoxin. Okay, fine.
Then the patient can be on diuretics, so sodium potassium has to be checked. Then ECG has to be taken.
Why the patient can be on diuretics?
Features of failure, and also for pulmonary congestion, to relieve the symptoms of dyspnea.
To decrease the preload.
Preload.
Okay.
Then ECG has to be taken. In the ECG, we have to look for rate, rhythm, if the patient is in sinus rhythm or atrial fibrillation. Then P-wave morphology to check for any left atrial enlargement, or P mitral may be there in V1 in lead 2. And then any features of right ventricular hypertrophy.
Why lead 2? You said lead 2, you mentioned. P mitral in lead 2.
Lead 2, P wave is picked up more.
Orientation of the lead 2 is towards the...
Lead 2 is from where to where? From which particular part of the body to the other part? The electrodes are placed. From the right arm to the left foot, isn't it? So it is in line with, or in the same axis as the heart. Plus, in 9th triangle, lead 2 is the sum of lead 1 and lead 3. That's why for all rhythm disturbances, you always go for lead 2. And all the waves are better represented in lead 2. Okay. P wave, you look for P mitral.
P mitral.
What is P mitral?
Because of the left atrial enlargement.
No, what is P mitral?
Bifid P wave.
Bifid
P wave.
Prolonged.
Bifid prolonged P wave.
Prolonged, how many small boxes prolonged?
More than 1.2, 3 to
No,
4
small boxes.
3 to 4 small boxes.
Yes, more than 3 small boxes, right. Then right ventricular hypertrophy. So all these can be there because your patient also has got a parasternal heave. So you expect a right ventricular hypertrophy in this patient.
What
So-
X-ray changes will you find if she's not pregnant?
Straightening,
mitral stenosis.
straightening of left heart border due to the enlargement of the left atrium and also the left atrial appendages, and also the left ventricle become small, and also the pulmonary aortic knuckle also becomes small. Then the double shadow will be present, and there will be splaying of the carina, and also the pulmonary corners become small. And also there can be antler sign or inverted mustache sign. There can be curly B signs, curly A signs, and there can be pulmonary hemosiderosis can be seen. And also you can also see bat wing appearance if the patient is in pulmonary edema.
Very good, very good. So invariably, the X-ray of this MS is usually kept for you in the afternoon for diagnosing and also for explaining all these signs, what you said, curly A lines, curly B lines, antler sign. Okay, so echocardiography is one of the most important investigation in this. So why echocardiography, and what all the information you can get from echocardiography from this patient?
Actually, by going for an echocardiography, you can see the valve, mitral valve morphology, valve area, valve thickness, the gradient across the valve, and you can also check for the other valves if there is, mostly if the patient is having right ventricular dysfunction, maybe having tricuspid regurgitation, and also can check for the pulmonary artery pressures, pulmonary artery. Then we can also check for the ventricular function, biventricular function, if there is any regional wall motion abnormality, and you can also check for thrombus in the left atrium also.
Okay, let us say, the patient was not on anticoagulants. Now echocardiography was done, and now left atrial thrombus is there. So will you go ahead and then take it up for elective procedures?
For elective procedure, we can wait.
Why?
Because on induction, the patient can have thromboembolism.
Yeah.
The LA clot can
Very high
migrate.
risk of thromboembolism. That's how echo is very important to rule out left atrial thrombus. So you may have to put her on anticoagulants and wait for the thrombus to dissolve then only, or even you can explain to the attendants also about this complication that can occur. Okay, now they have decided to induce this patient. So now they want labor analgesia. Is labor analgesia is very important for these?
Yes,
mothers?
labor analgesia is important because pain can increase the heart rate. We do not want increased heart rate in this patient. Also, pain can increase the SVR. So, labor analgesia decreases both of that. So, and it's preferred. And it decreases the risk.
The patient is in stress, pain, and anxiety. We want to decrease all these factors to these patients. These all factors can cause the release of catecholamines and cortisol. Cortisol can cause hyperglycemia. Catecholamine release can cause increase the SVR, so decrease the blood flow to the uterus, and also can cause uterine contractility, increase the contraction.
No, all those things are
All those
for
things.
all patients, especially for this patient
Decreases the
with
preload.
mitral stenosis.
Decreases the preload, and also because of the
Increases the-
vasodilation later on.
Mainly
it
the
can have
heart rate. Any increase in heart rate, they just cannot tolerate, because the LAP will increase, left atrial pressure, back pressure, they can even go for pulmonary edema. So that is one of the most important thing. So you see something called as a cardiac delivery is there. Can you just tell me what are the features of cardiac delivery in these patients?
In cases of severe mitral stenosis, we may want we have to give early labor analgesia for these patients because we do not want any increase in heart rate. And during the later stages, also we do not want the mother to bear down, but as it further increases the sympathetic activity and decreases the uteroplacental flow and increases the SVR. And also because
second stage of labor, to shorten the second stage of labor, you can try for forceps or a instrumental delivery.
Yeah. So this is what is called as cardiac delivery. So that the stress on the cardiovascular system of the patient should be reduced as much as possible. Okay, what is your technique of labor analgesia in this patient? For example, now this patient, she has got class 3, and I'll say that her valve area is less than 1.5 square centimeters, because you have to, by echo only, you know that whether she has got a mild, moderate or severe mitral stenosis based on the valve area. So, okay, she has got less than 1.5 square centimeters.
So this is a case of moderate MS. I would like to go ahead with labor analgesia. I would choose combined spinal epidural in this patient. After getting informed consent,
So why combined spinal epidural? Why not only epidural?
because
Any particular reason for combined spinal epidural?
we can give lower doses of spinal local anesthetic and produce a higher.
No, which one produces a better analgesia? Is it combined spinal epidural or only epidural?
Combined
Combined
spinal
spinal
epidural.
Why combined spinal epidural can produce a better analgesia for these patients? For anybody for that matter.
Because it is rapid and
No, rapid you don't want, isn't it?
we are injecting local anesthetic in subarachnoid space. And
No, the
also
main
there
thing,
is
the
epidural.
sacral analgesia will not be there if you just give epidural only many times, especially the second stage. They may have severe pain that we have seen. So when you have placed or made a hole in the dura, even dural puncture epidural is also quite popular. So you make a hole in the dura and you need not have to inject anything inside the interthecal space. So sacral analgesia will be better. That's how, combined spinal epidural may be better. So suppose she's being posted for elective section now. So, and less than 1.5 square centimeter, why I said is, normally less than 1.5 square centimeters and above 1.1 in non-pregnant women, you can say it is moderate. But here there are only two things, above 1.5 and below 1.5. Even just below 1.5 square centimeter of the valve area, you should consider it as a severe because the flow across the valve is very high. Based on, the Garland's formula and all, we know. We did not go into, too much about the pathophysiology here because of lack of time. That is very important for you to know about. So in these patients, even less than 1.5 square centimeter should be considered as a severe one. Now for this patient, how are you plan your anesthetic technique? Would you go for a regional anesthesia or a general anesthesia? And let me know about your reasoning for each.
In this patient, as the patient is already on labor epidural, we can
No,
convert.
she is not on labor epidural. Elective section.
Okay. Regional anesthesia is preferred.
That is gone. That is over. That labor analgesia part. Okay.
Okay.
Elective section.
If she has presented for emergency section.
Not emergency. Elective section.
Sorry. Elective section.
So she can be posted for emergency also. That also a situation may be created for you in the exam. You may be asked. So elective cesarean section because of obstetric indications, let us say.
I would prefer regional anesthesia, combined spinal epidural in this patient and graded doses of epidural. Ropivacaine 0.12% with 2 microgram per ml of fentanyl.
Now what precautions you will be taking for providing combined spinal epidural in this patient?
In this patient, we do not want any tachycardia. So test dose lignocaine without adrenaline is usually preferred. And also...
No, combined spinal epidural means routinely what majority of the time we give is spinal anesthesia for the procedure, epidural for post-op analgesia. Would you be doing that same thing here? In a patient with mitral stenosis with less than 1.5 square centimeters?
I would prefer the patient to sit and...
We have another 10 minutes.
Sir, we have 1 more minute, 1 minute, 42 seconds left.
Oh my God. Okay.
I would prefer a
No.
sitting.
Here you go for a low dose spinal with epidural, if at all. That is just 1 cc of intrathecal hyperbaric drug, and then followed with, it is also called as a sequential combined spinal epidural because you don't want rapid fall of systemic vascular resistance. That's how 1 ml. Okay. Now, okay, if she's, some contraindication for spinal is there, you have to give GA. How GA is different in this patient compared to GA in any other pregnant non-cardiac patient?
In this patient, the goal, anesthetic goals would be to avoid any forms of tachycardia. Then,
So before that, even for any surgery, prophylactic antibiotic therapy is indicated, not indicated?
Elective cesarean section, so we don't want to give infective endocarditis prophylaxis.
Okay. Suppose If she has a prosthetic valve, mechanical prosthetic valve,
Yes.
I would.
Less than.
then also not required as such. It's a oropharyngeal gingival invasive procedures only. We nowadays restricted. Okay, prophylactic antibiotic therapy not required. Then
Avoid tachycardia, maintain sinus rhythm, maintain the preload and afterload and contractility, avoid hypoxia, hypercarbia, acidosis,
Okay.
hypothermia, and maintain the patient in the left lateral.
okay, those are all goals, right? Continue.
Continue. I would get consent.
No, anything different from GA for
I would
non-cardiac pregnant patients?
Rapid sequence induction is preferred. I would
Okay.
induce the patient with titrated doses of etomidate and
No, pre-medication. Normally, we don't use opioid pre-medication in other pregnant women, non-cardiac pregnant women, because it can immediately cross the placenta and then can produce fetal depression, neonatal depression. So here, will you give or you don't give?
we give sedatives, pre-medicating sedatives can
No,
be
fentanyl. I'm
We
asking.
can give
Fentanyl is not a
we
sedative.
can give fentanyl if you want to avoid the tachycardia during the intubation. If
That
at
is
all
very important, isn't it?
if at
So-
all we are giving the fentanyl, we will inform the neonatologist about the that we have given fentanyl to the patient.
Okay, that is one important change when compared to non-cardiac pregnant woman posted for section. So what is the other thing, like, for example, if you want to induce with propofol, do you have to take a lot of precautions when you induce with propofol? In this,
propofol can produce drastic hypotension and also decrease the SVR, so leading to hypotension. So we have to put a intraarterial monitoring can be done.
no, it depends on invasive monitoring, depends on the severity of the
The
disease and magnitude of surgery. So severity of the disease, you can place. So here, propofol, if you want to give, you have to go for a sleep dose. Normally for rapid sequence induction, you calculate the dose of propofol required for that patient and you give the full dose. But here you have to go for a sleep dose. So let us not discuss about how you will give sleep dose. Okay, propofol or etomidate, nowadays it's fine if you think that propofol is, can produce problems in this patient. And succinylcholine definitely you will give. So what intraoperative complication you expect and when actually that particular complication can be produced? Most important intraoperative complication.
The patient can go in for pulmonary edema or atrial fibrillation or
Okay. When pulmonary edema can occur in these pregnant women with cardiac disease?
after the delivery of after the baby is taken out, there can be autotransfusion, increased amount of blood is entered into the circulation. So the preload can increase and the patient is prone for a pulmonary edema.
Yeah, one is sudden increase in the preload of 500 to 800 ml. Second, the compression on the inferior vena cava is not there. So these two are the reasons why. And suppose if she develops pulmonary edema, how do you manage? This is the last question.
We can increase the FiO2 to 100%, increase the inhalational agent to deepen the planes of anesthesia, give a head-up position, then give morphine.
PEEP.
No, would you give a diuretic anticipating that she may develop pulmonary edema? Because you always anticipate. It's very commonly likely she will develop pulmonary edema.
We can give injection lasses 40 mg.
Yeah, before only.
Then
Just as they're doing an extraction of the baby, you can give and then elevate the head end. So that will definitely help.
we can give PEEP also, and then morphine can be given 0.1 mg per kg.
Okay, all those things you should always know. And management of atrial fibrillation intraoperatively.
There is rate control and rhythm control. Rate
No,
control
intraoperatively, suddenly if she develops atrial fibrillation.
Esmolol can be given 0.5 mg.
So majority of the times they'll have cardiovascular instability. So you go for cardioversion. Cardioversion. Intraoperative atrial fibrillation, many times you may have to go for
Synchronized cardioversion.
cardioversion. So again, you'll have to think about the post-op analgesia in these patients. Very important. So lot of questions can be asked, and mitral stenosis in pregnancy, you can discuss for 2 to 3 hours easily. But unfortunately, we have less time, and you people have answered very well. So Madam has prepared you very well. Thank you. Thank you so much.